Hi, friends. Thank you so much, Kelly. Happy New Year to everyone. My name is Annie Behr, and I'm the clinical coordinator for the WVU Positive Health Clinic. We're a Ryan White Part C and D funded outpatient HIV program located in Morgantown, West Virginia. And today I'm going to talk a little bit about a way that we have developed to initiate patients in rural settings on antiretroviral treatment as quickly as possible, and talk a little bit about some of the tools that we've done to do that in service of getting folks to undetectable, which really speaks to the goal of treatment as prevention. Let me see. Okay, is my screen visible, Kelly?
Not yet.
Okay. So sorry. I wish we hadn't hit record just yet. That's okay. What do I need to click on to share my screen? This is different than.
There should be something on the bottom that just says share, and you can hit that.
Sorry. Teams has me trained, so that's what I'm used to doing. Okay, what about now? Better?
Beautiful.
Okay,
Yep.
super. Thank you so much. Okay, so we're talking a little bit about how we're addressing prompt ART initiation, particularly in rural communities. It's not uncommon for my patients to be 2 and 3 hours away from me. So the idea of a same day rapid start, while wonderful, isn't always achievable. There are a few, oops, why is now my buttons are, there we are. So this project is supported by HRSA. The Ryan White AETCs are funded through HRSA's grant funding. The comments reflect my feelings and don't reflect the feelings of the government, HRSA, or HHS. Here's a little bit about, if you're not familiar with AETCs, they're a wonderful program located all across the country that provide HIV education to a variety of care providers. So if you're not already familiar with your AETC, I would encourage you to do a little research and find your local AETC program. Their goal ultimately is to just strengthen HIV care by supporting education. I have no disclosures, and any medications that I might mention during this presentation are simply for teaching purposes only. And then, okay, so our learning objectives. Today, we're going to talk a little bit about some of the challenges that I know our patients face when they're in rural or more isolated areas as they try to engage, first get tested and then engage into HIV care. We're going to talk a little bit about a remote rapid start program that we've initiated here at the Positive Health Clinic for almost 2 years now, and some of the things we've learned along the way. And then I'm also going to share a little bit with you about a tool that we've developed that I call the Remote Rapid Start Pathway to help clinical staff go through the steps of a remote process and learn a little bit about that, all the thinking behind how we do a telephone intake with a newly diagnosed individual. So first, you may be familiar with this already, but if you're already serving a rural community, you may be nodding your head along, but we've known over the last few years that HIV care in the United States is shifting. We're seeing an increase in new cases in more rural settings. There's a variety of factors, including injection drug use and substance use. And then some socioeconomic issues, just geographical things. And we still run into it quite frequently. Folks in rural communities just don't think that HIV is an issue in the rural areas. They still associate it with larger cities where the epidemic first kind of reared its head back in the 80s and 90s. This is just a map now, an example of so the yellow area is our Ryan White funded service area. I'm located at that sort of center star in Monongalia County. We cover 33 counties. We also provide care for patients who drive over from Ohio. They drive down from Pennsylvania and over from Maryland and Virginia. So it is not, like I said earlier, it's not uncommon for my patients to be traveling 2 and 3 hours one way just to see us for care. We have very limited public transportation outside of the county that I'm in, Mon County, with very little public transportation in the state, and a lot of challenges using non-emergent medical transportation through a program like Medicaid. So just lots and lots of barriers for folks to even be able to get to me to initiate care. So that's where this what we've done now is this remote process with using telephone. Um, Next, just some additional information. What we see are the barriers to rural HIV ART initiation. For those of you who provide HIV care, I'm sure you're very familiar with the treatment guidelines that recommends initiating ART immediately or as soon as possible, which is great when you have the patient right in front of you. If you represent a program that has, say, status neutral care provision where a individual comes in for testing, if they're negative, you can walk them down one corridor for prep, and if they're positive, you can introduce them to a provider for an ART start. And again, my patients are going to be hours away from me potentially if they're tested by a DIS worker or at a local health department. And so just to save a lot of time and transportation challenge, we're doing this a lot over the phone. So some of the barriers we see, I said transportation, limited public transportation, limited number of providers that we have that are treating HIV. That's one thing that's great about programs like ECHO, is that there are projects out there to help empower providers that are serving more rural communities to do HIV treatment, prep care, increase the number of testing. But there's still a lot of parts of the country where people have to travel really far to access that kind of care. And then lastly, I touched on it in the beginning, the fear and stigma associated with even requesting HIV testing, or then if a patient does find out that they're positive, taking the leap to jump into care, and what that means for them, and will people find out about their status. It's really, that's a big barrier for folks a lot of the time. So our previous new intake process was a multi-step one. We would get a referral of a newly diagnosed individual, and they would travel to Morgantown, to Monongalia County, where I showed you on the map, to meet with our nursing staff to complete a intake, just a lot of getting to know the patient, asking some history questions, and then doing a whole intake lab collection panel. We would then have them return a couple of weeks later to meet with the provider for the very first time, and talk about starting ART initiation at that time. That means, multiple potentially lengthy trips to Morgantown, potentially missed work or school. Oftentimes, if we ran into scheduling issues, if the patient couldn't take off work or they had childcare needs, sometimes they would have to postpone those visits with the provider, which meant they would postpone their start to ART. We do represent a small program here. We only have 2 days of clinic available. And so there's only 2 days a week that the patients could come and complete these intakes, which, depending on their availability, would present a bit of a challenge if, say, they only have Mondays off and we're only available Tuesdays and Wednesdays. And it also intakes, as you may know, when you're counseling people who are newly processing how to enter into care for their HIV status, they can be very time consuming. You can spend a lot of time educating and counseling the patient. And there have been periods of time in the last few years that our staff has been very, very small. And so if you only have 2 clinical staff taking care of a whole busy clinic, and you pull one out to do an intake that takes 2 hours, it's really, really kind of slows things down in terms of the rest of the clinic flow. So what we did, it was really almost in response to COVID. Our program was closed for the first 8 weeks of COVID, and we were suddenly forced to figure out how to do things remotely by telephone. And what we found quickly was that we could accomplish a lot of this over the phone. So our new process now includes a nice long telephone intake, as long as the patient agrees to it. If we usually will explain to them, you can either come meet me in person, or we can have this conversation over the phone. And very rarely do I have somebody who is not willing to complete the telephone intake. WVU is part of a larger WVU medicine healthcare system, and so we're fortunate in that we have more than 20 now different hospital locations scattered across the state, which has made our intake lab collection much, much simpler. It used to be, if somebody was going to a lab or phlebotomy location that was outside of our healthcare system and we were faxing orders, inevitably the orders would be collected wrong, or there'd be things missing. And again, that's just going to lead to time delays. So now that I can refer a patient to their closest WVU medicine lab location, I know that the lab orders that we place are going to be done correctly. I can tell them when I'm going to have their results. I can call them a couple days later. Here's what your CD4 is. Here's what your viral load is. And so it's really streamlined our lab collection process. It just expanded days of the week in terms of availability. I can arrange to, our staff can arrange to have an early morning chat with a patient if they need to talk before work, or even I've had folks who, work night shift and they want to talk before they go to sleep during the day. I've arranged to talk to folks in the evening, but it just allows for more availability. I also find that when folks are talking to me from their home, they feel more comfortable asking questions. I can hear them. They're at home with their pets. They're in the comfort and security of their own home, and they're really able to ask a lot of questions, and we can really get into a lot of really good, health history collection. And they're receptive to a lot of the education that I'm offering to them. It just allows for more time. And as we're having those conversations, one of the things I'm trying to assess is, do I think they would be interested in starting antiretrovirals even before they meet with a provider? I'm still working on putting together the data from 2025, but in 2024, the Positive Health Clinic received referrals for 53 new patients. And of those new patients, about half of them were newly diagnosed HIV patients. And then I have the breakdown further on. So of the 26, 11 patients were initiated on antiretrovirals through this telephone remote rapid start pathway. 6 patients were started on HIV treatment by bringing them in more quickly to see their provider. And I can get into why we felt those individuals would do better with a clinic start. We're still seeing a significant number of patients every year who are not diagnosed until they're very sick and inpatient. So 8 of those referrals were started during hospital admissions. And then we did have one patient who I was very optimistic about a telephone rapid start, but after our intake call, he kind of ghosted me for 4 months. I think he was still sort of processing things, but he did finally, after that 4-month time period, he did get back in touch with me, and we brought him in and got him started as soon as he reached back out. So some of the reasons that we felt like those 6 patients should be brought into the clinic, the main reason those 6 individuals were brought in was really language barriers. There were individuals for whom English was not their first language, and we do have the ability to do telephone translation services that we can, call the language line, and then the language line calls the patient. But and we've done that. But what I find is sometimes it just seems like there's sometimes a little bit lost in translation, so to speak. And then in our clinic, we have the ability to do video translation. So you're actually seeing the patient, seeing their facial expressions, and then we have the translator on video screen. And that, for those individuals, just seems like a little bit better of a way to make sure that no details are being missed, no educational points are being overlooked or misunderstood. So that was really the primary reason that those 6 individuals, we felt like we were going to sort of bring them in to meet the provider more quickly. So I'm going to go over a couple of examples of our process for remote rapid start. And then the third, I will give you sort of a what would you do example. So our first case study that I'm going to share is a 34-year-old white male patient who on December 7th presented to his local health department for testing after he had done 2 home HIV tests that were positive. His risk factor was that he is a male who partners with other men. The health department then referred him the next day on December 8th. I was able to talk with him the day after that on the 9th to do that telephone intake call, and he was able to have his labs collected the very next day. His CD4 count was 443, 25%. So pretty good there, and his viral load was a little over 100,000 copies. I discussed my conversation with the provider, and she approved, and so we went ahead and initiated the patient on antiretrovirals on the 12th. He confirmed later that he was able to pick them up that day. Over the next month, I reached out to him for a couple of telephone check-in calls just to see how he was doing. The initial intake call when a patient expressed interest in starting antiretrovirals quickly. I'm talking with them about adherence and side effects and sort of the secret to success for those kinds of things. And so then I'm constantly just touching base, have you had any issues with remembering to take your meds? What are the tools that are you setting a reminder on your phone or things like that? And then just answering questions. It's a whole new world for people to process. And so sometimes we'll have a great conversation on the phone and it'll, a week later, a question will pop up. And so I'm wanting to make sure that I'm addressing those questions. A few weeks later, he presented to meet with the provider on the January 10th, at which time he was almost undetectable. His repeat viral load was 40 copies. I didn't realize it at the time, but when I was going back over and putting this data together for these slides, I realized December can be a really tricky month for seeing patients, right? You have staff taking time off for the holidays. Patients might not be available because of the holidays. And so I don't know how quickly, if he had wanted a clinic start, I don't know how quickly we would have been able to get him in. But the fact that we got him in and almost undetectable, started on antiretrovirals and almost undetectable over essentially the Christmas and New Year's holiday felt like an extra win, I suppose. Typically what we'll do is we'll schedule that new provider patient visit with the doctor 4 to 6 weeks after they tell us they've started their antiretrovirals, because we know we would have been bringing them back at that point anyway, to follow up and see how they've responded to treatment. So here are some of the things that we kept in mind when we were looking at this patient and considering him for rapid start. So, and this is a big one. I understand this is a very big consideration. He already had active insurance. And you guys know, if you're doing medical case management or trying to get patients started any kind of treatment, if they don't have insurance, that can often be a big hurdle. It's not a deal breaker, and we have ways that we can get folks antiretrovirals. But obviously that's a nice check in the pro column in terms of, is this doable? It also speeds up the process of labs, and what it means the patient doesn't have to wait on applications, approvals, Medicaid denials, all those kinds of things. He had a remote history of seizures, but he was well established with neurology and was stable on medications. And that showed me that he had a good sense of medical literacy. He was familiar with the idea of having a chronic condition that needed periodic follow-up, and he already had the muscle strength developed around adherence. It's very tough, I think, for folks who never take any regular medications to suddenly start taking a daily pill every day and not forget. But for somebody who already has that habit, it was very easy to kind of add one more pill on. Did have a history of depression and anxiety since childhood, but he was very stable, managed by his PCP. Again, that speaks to healthcare literacy and understanding the adherence counseling aspect of things. He denied any history of active alcohol or substance use disorder. And I always like to pause here and say that is by no means a deal breaker. But if patients do report an active or ongoing alcohol or substance use, that's where, as a part of the conversation, where I kind of break it down a little bit and I explain that those things don't necessarily negatively interact with the medications themselves, but if that substance use or alcohol use prevents them from being able to take their meds on time, that's when it can become a problem. And then it's just an opportunity for us to kind of dive in and investigate a little bit further. Another thing that I've noticed in interviewing folks in this way is sometimes it's the first thing out of their mouth, and sometimes it's something they bring up a little bit further into the conversation, but they will use what I call buying questions, or something that our medical director refers to as emotive readiness. They'll ask questions like, when can I start? How soon can I get my meds? How quickly can we get this going? I wanted to start, I'm ready to start yesterday, those kinds of things. That's letting me know that their thought processes, they're already putting themselves in the place where I want to take this pill every day. I want to get this started. It gives them the opportunity to sort of feel like they get to fight back a little bit, which is nice. Our case study number 2 was a 31-year-old white female patient who was diagnosed towards the end of January by her primary care provider and was referred to the Positive Health Clinic from her local DIS, who had interviewed her a few days later. Her risk factor was heterosexual contact. I completed a telephone intake a few days later, and we were able to order her intake labs. But unfortunately, she had some other underlying health issues. Before she was able to present to her local lab for collection, she ended up being admitted to the hospital with some kidney and blood pressure issues. At that time, they drew labs and found she had stage 4 chronic kidney disease and had to start hemodialysis. Um, we were able to collect her CD4 and viral load during that admission, and her CD4 was good. And interestingly, her viral load was very low. She was then, during admission, started on a renal-friendly antiretroviral regimen prior to treatment. And we were working with her pretty closely in our outpatient clinic. And she was also referred to the renal transplant program here at WVU, but she unfortunately passed away unexpectedly about a year later. After my talking with her extensively and getting some information from the DIS and the PCP, her situation was a little bit different. She did have Medicaid, so she did have active insurance, but she had big barriers to transportation. She herself didn't have a car. She was having to rely on rides, and she was so far away in such a remote part of the state that the non-emergent medical transportation that we do have available in the state is less reliable the farther and more remote and rural you get. So that was going to be a big barrier. And then the primary care provider and DIS that met with her were really concerned about her health literacy. They weren't really sure how much she was able to sort of take in and process. And I felt that way too after I chatted with her for quite a bit of time on the phone. She just didn't really seem to understand her HIV diagnosis. She didn't really understand that she was going to have to come for visits with us. And again, this was even before we found out about the kidney issues. Um, uh, she really needed a lot more support. So our plan at that point, when I talked about it with the provider, we determined we didn't think she was a good candidate. And our initial plan was to bring her in very quickly to meet with the provider. However, that plan changed when the admission happened. She was able to get started on treatment very quickly, but it was as an inpatient as opposed to an outpatient. So why are we talking about HIV treatment at a more prevention focused HIV education, ECHO experience? Because all of these efforts that we're doing to get patients started on antiretrovirals as quickly as possible speaks to our goal of viral suppression, which is in service of treatment and prevention, right? So we know that if we can get a patient to undetectable, U equals U, undetectable equals untransmittable. And these are just the ways that we have developed to try to get folks to undetectable as quickly as possible and minimize the challenge of being in a rural setting or a more isolated setting. So treatment as prevention or TAS, some people will say. Okay, so my next slide is a what would you do? I'll read it through and then you can either send a thumbs up or a thumbs down, or you can maybe put a question or a comment in the chat if you want. But so our next example is another case that we did, and you can share what your thoughts would be. So we had an individual 30-year-old male who requested STI screening during a new primary care visit to establish care. His previous HIV test from 2 years prior had been negative in the computer system, and his risk factor was that he partnered with men. The primary care provider did notice that he had bilateral swollen lymph nodes during the physical exam. And in addition to all the other STI screening, they did order an HIV test. And this was interesting. His combined antibody antigen screen was reactive, but the confirmation and differentiation was non-reactive. And so, rightly so, they did a tiebreaker. They drew a viral load, and it showed over 10 million copies. And so that is probably highly suspicious for acute retroviral syndrome. I always like to stop here at this part of the conversation because this patient unfortunately learned about his HIV status through our EMR patient portal. So here at WVU Medicine, we use Epic, and patients. A couple of years ago, CMS came out with a rule that all patient records and information belong to the patient and should not be hidden. And so what that means now is that patients are getting cancer diagnoses, biopsy results, and HIV diagnoses in their MyChart or whatever their patient, facing portal is. This gentleman unfortunately checked his phone at about midnight and got those results and was up all night long in an absolute panic, didn't have anybody to talk to because unfortunately it was at midnight, didn't know that he would see those results, so he wasn't necessarily prepared for that information. And I just like to I never want to do anything that would dissuade providers from feeling comfortable ordering the HIV test, but I do think it's important that if you're ordering that test for a patient and you tell them, if you have my chart or whatever your institution's version of a patient portal is, the patient's almost guaranteed to see the result before you will. It's happened a couple times for our patients. You can imagine how upsetting it could be if they were not prepared to see that result. So we actually crafted a message now. If a patient gets a positive HIV test result, we asked the lab and the IT people to help us. We crafted a message that presents at the bottom of the lab that tells them, this indicates you're living with HIV infection. And basically it tells them, if you're reading this message during, Monday through Friday daytime hours, and it lists a telephone number, it's my number, they can call for more information. And then we have a 24-hour sort of on-call service through our institution. So if for this individual who got his results at midnight, he could have called and requested to speak to the infectious diseases provider who would have been on call that night, and they could have counseled him through like answering those initial questions and things like that. So it doesn't happen often, but it's very upsetting for the patients that do. So I do encourage folks who are ordering HIV tests to know about that and make sure to mention it to patients. Additional information. So the patient and I completed a telephone intake. As soon as I got in that morning, he had called in through the call center and they tracked me down, and you can imagine the kind of mental state he was in. He'd been up all night long. And so I was really just trying to get a sense of supporting him and answering his questions. He had a history of generalized anxiety disorder, PTSD, and bipolar 1. But the good thing was he was already very well established with psychiatric care and had a therapist he saw very regularly. He'd also already sent messages out to them, so they were aware of this diagnosis. He was really very self-aware in that way, which was great. Part of our intake process includes a PHQ-9, which he declined. And the wording he used, he said, was he felt a little dissociated. And I thought, well, sure, he'd been up all night long, upset about this. That made a lot of sense. But he also denied, when we were chatting about that, any real acute worsening of his depressive symptoms, and he had no SI at that time. He was reporting some ongoing issues with sleep, talked a little bit about occasional THC or CBD use, but denied any other symptoms. And then additional labs showed, so we knew that viral load was super high, right? Over 10 million copies. CD4 count was good. His A1C, interestingly, that was one test that the PCP had drawn, and that was elevated. And his AST and ALT were also a little bit high. Another thing that was helpful was he already had active West Virginia state medical insurance. So, all right, what would you do? Would you feel comfortable counseling this person over a telephone intake, or would you bring them in? Like I said, you can send some thumbs up on the screen, or you can put something in the chat. Anybody have thoughts? I realize now I've done this wrong. I can't see. So if people are sending things, let me see. If people are putting things in the chat, unfortunately, I can't see them where I was sharing my screen. Sorry.
That's
Do
okay.
you want me to read them, Annie? Oh, sorry, Kelly.
No, you're fine. I was scrolling down through them. So Courtney said, recommend next steps to prevent anxiety and a multitude of possible outcomes. Also, 24-hour telephone support is excellent. And then Robert said, I would counsel them over the phone since they have a therapist.
I didn't catch the last part. I will counsel them over the phone.
Since they have a therapist.
Okay. Great. Yeah. All good thoughts. Thank you so much. And again, this is like key treatment is prevention, right? Because with a viral load of greater than 10 million copies, if he was not aware of this new diagnosis and was having unprotected sexual encounters, that's a big concern. So just empowering him to feel good, to process this information, feel good that he now knows it, because he can take the best possible steps for his health, get started on treatment, and get that viral load down really quickly. So thank you guys all for your comments and thoughts on that. hang on, I scooted my screen out of the way and I lost my, okay, there are my arrows. All right, so what did we do? We started him. I offered him a remote rapid start and he was very agreeable. So I started him very quickly. We did telephone check-ins. This was early on in the process. I mean, I feel like the earlier case study that we showed is like best possible scenario, but we're humans and we do human-y things. And so it doesn't always go to plan. We had a new patient visit with the provider. He reported 100% antiretrovirals, which were great. He reported that he'd been having night sweats and they were starting to improve a little bit. We weren't sure, was that an acute retroviral syndrome or was he having a little bit of obstructive sleep apnea? You know, not quite sure. The intention was for him to have his labs that day, but we forgot to order them and he didn't get them drawn. And like I said, humans do human things all the time and that's okay. He then no-showed for another follow-up appointment. And so we were able to complete that return visit, obviously outside of the recommended 4 to 6 week typical guideline, you know, advised follow-up labs. But by the time he came back in January, he had already quit smoking. He'd improved his eating habits, you know, that kind of addresses that A1C. His primary care provider had started working with him on that elevated A1C. He was reporting pretty good adherence for his antiretrovirals, and he went from over 10 million copies down to 208. So that was really, really significant. And it felt like a big win for him to see such a huge number go down, you know, to almost virals. If we just maybe drawn him one day later, he would have been under 200. So that felt like a big win. So how do we do this? We do this over the phone through this remote rapid start pathway. And it's a process that I've sort of developed and honed. You probably all do things very similar, but I think it can be helpful to kind of talk about the structure and framework of it. It's a template that we use to support those telephone conversations. I think of it, they're step-by-step, but not ABC. If any of you remember Choose Your Own Adventure books from back in the 80s, those had a grip on me when I was in middle school at the book fair. And you could, you know, you'd read through and you'd get to the end of it. If you want, you know, Sally to go down the old abandoned mine, turn to page 17. And if you want her to go home and call her friend Sam, turn to page 35. You can take a patient through all these things, but it doesn't have to be quite so prescriptive. A lot of times I'm letting the patient guide the conversation. So if I'm talking to an individual and the first thing they start talking to me is about, you know, substance use and maybe a pass with needles, you can quickly shift to the substance use mental health section of the pathway and cover that. And then you can always backtrack to get all the other information. Other patients immediately will start talking to you about sexual encounters and past partners, and you can zip to that section. You don't have to do it all in order, but eventually over one phone call or a couple of phone calls, you're going to be able to gather all that information. The other thing that I think can be really helpful about this kind of a process is if you're working with individuals who are new to HIV care, there's a lot behind the scenes for folks to keep in mind when you're talking to somebody over the phone. And if they're new to HIV care, they may understand what they're asking, but they might not have a strong handle on the why they're asking it. You know, about things like cough or, you know, blurry vision or issues with balance and all those kind of little things that folks who've worked in HIV for 20, 30 plus years are going to be familiar with, you know, particularly related to opportunistic infections. But for folks who are newer to HIV, here in West Virginia, when we're hiring new staff, it is rare for us to have the opportunity to onboard a new staff member who has any HIV experience. And so we're providing a lot of that support. And so having a tool that they're using that's teaching them while they're teaching the patient, I think can be really useful. So these are all the different sections of this pathway, and you can see it's pretty extensive. You're talking about just I'm talking to patients over the phone about a general kind of head to toe, how's their health? I'm finding out from them, what do they already know about HIV? And then trying to support or you know, tweak little things along the way. Sometimes you might be surprised at answers people will give you. I had one individual tell me that they thought that uncontrolled hepatitis C turned into HIV. So obviously that was an opportunity for she and I to sit down and really kind of break down, explain that those are two very separate things. We're talking about substance use, mental health, other health issues. What are the other barriers that are going to prevent a patient from if our ultimate goal is to get to undetectable, what are any barriers along the way that are going to prevent them from doing that? What are other health issues they have going on? We're talking about insurance, talking to them about Ryan White services and other care services maybe potentially available in your area that you can connect the patients to. Sometimes patients will say, just put me in touch with everybody. Other patients will be still processing the information and that feels a little too overwhelming for them. And so you'll be their contact for them, and they might want referrals like slowly sort of, portioned out a little bit here and a little bit there. We're going to talk about antiretrovirals themselves, talking to them about, are they interested? Are they, do they sound ready? Educating them on the labs. What does the CD4 mean? What's a viral load mean? I'm also letting patients know and reassuring them that it feels like they're learning a whole other language, right? And it is. They're having to learn about the world of HIV. And then we're talking about planning appointments, wrap-ups. I usually joke with them about, like I'll tell them, these are the things I'm going to be working on for you behind the scenes. I want you to do X, Y, and Z. This is your homework, those sorts of things. This is an example of what our telephone intake is, and it includes the rationale. So you'll see for the health assessment, you've got the questions in bold black, and then underneath of them are the rationale in italics, the why we're asking these questions. So that's what I mean when I say I think a tool like this can be useful for people who are brand new to HIV or maybe don't have 20, 30 plus years of HIV care experience. Why are we asking about headaches, or blurry vision, because what I'm then doing is I'm taking all this information that I've gathered from the intake and I'm talking to the provider about it, and they're going to take my information and their lab results and determine, yes, this person's a good candidate for a rapid start, or, ooh, I'm a little worried about this, this, and this. Maybe we should bring them in immediately. And so this is the why I'm asking these things. And like I said, it's 7 pages long. Originally, it was a beast. It was like 11 pages. I was able to pare it down a little bit, but we're going through all this information with them. And again, I do find folks seem to be more comfortable doing this over when they're just in the comfort of their own home. And we are covering a lot of information. My longest telephone intake clocks in at nearly 3 hours, but I did find out sometime after that the patient was probably on ketamine, so that might have had something to do with it. So we're talking about, additional resources, ART education and readiness, the labs, all the things. These are all the things, and it includes the rationale. If you are interested in this intake, I have both the rationale version and the blank version with just the questions. If that's something that you think you might be interested in terms of utilizing it in your practice or taking it and tweaking it, I'm happy to send out electronic versions of it. I've got Word versions of both. Because I think it can be a useful tool. It might, not all the parts might work, but it might give you the opportunity to see it and create something similar for your version. So here, last screen, here's my email. If you're interested, like I said, call me, reach out to me. If you think a tool like the Pathway might be helpful as you're working towards the goal of getting people undetectable as quickly as possible.
If you would like to send me that flyer, I can actually upload it for everyone to access on iEcho.
Yeah, you mean the Word document itself?
Yeah.
Sure. Yeah, I can send you both. I have one that has the rationale and one that does not, so I'll send you both.
Okay, yeah, and then what I can do is I can just take and upload that to iEcho, and people can just download it from there.
That works. I am happy to entertain questions and comments if anyone has any.